I am district coordinator with my sub-coordinator, Dr. Tuti Tauri and Dr. Swami Sina. During the webinar, if you have any queries or questions, please post them in the chat box section, which would be answered at the end of this session by our webinar person. Now, let me give the brief introduction of our webinar person, Dr. G. Varadharajulu. He completed his graduation from Dr. MGR University, Chennai, Tamil Nadu, and post graduation from School of Medical Education, Mahatma Gandhi University, Kottayam, Kerala. He's PhD scholar in stroke rehabilitation. He has varied experience working. He started working in Sridevi College of Physiotherapy, Tumkur in Karnataka, as in charge and lecturer in physiotherapy. Now he's working as a dean of Faculty of Physiotherapy in Krishna Institute of Medical Sciences, Karad, Satara in Maharashtra. I'm glad to present such a versatile and experienced Dr. Varadharajulu, who is not only has a clinical professional, but remarkable administrative skills. So, sir, I welcome you from bottom of my heart. I'm very thankful that you have accepted our invitation to give this webinar, sir. So, without wasting any time, I present to you Dr. Varadharajulu. Sir, over to you, sir.
Thank you very much, madam, for your wonderful introduction. And I wholeheartedly congratulate the Women's Cell of Indian Association of Physiotherapy for taking the efforts of conducting the various academic activities across the country. And in that, Maharashtra Women's Cell, I'm very happy that Maharashtra Women's Cell is leading and conducted more than 60 workshops, 60 lectures on various topics of need of the hours. I congratulate all the people who are behind the screen and working this particular achievement. So again, it's my great pleasure and privilege to be the part of this particular webinar. And I'm very much thankful for the organizers of Women's Cell of Varda, especially Dr. Swami Sinha madam, who is my teacher and who is my mentor during my studentship, and for giving me this opportunity to deliver a talk on this particular topic of my choice. So, today's topic is the concepts of neuronal plasticity. So, just I thought of this topic because I being the neurophysiotherapist, so I wanted to share for the younger generation, especially certain basics of neurorehabilitation and certain basics of how the neurological patients are improving after our intervention. So this kind of enlightenment I wanted to give it for the younger generation, even to the physiotherapists who are working with various neurological disorders. So when we talk about the neuronal plasticity, we all think that it's a new topic, a very advanced topic or like that. No, it is a part of the physiology which is happening in our brain, in our nervous system, once it is getting injured, once it is getting affected. So how this normal physiology is being taken care, how this normal physiology will be activated or facilitated, will be the entire content of this particular series of particular topic that we are going to discuss. So it is more, so before going into the topic, let me orientate what are all the neurological disorders? So the neurological disorders are basically classified as upper motor neuron lesions and lower motor neuron lesions. So upper motor neuron lesions, we all know that it is the injury, the lesion occurs in CNS, especially from the brain till the spinal cord. And lower motor neuron lesion means from the motor neuron to the entire peripheral nerve till the nerve end plates, where the nerve enters into the muscles. So this is what is the basic classification of neurological disorders, which all the professionals knows it. So upper motor neuron lesions and lower motor neuron lesions is a very much common basics. So now, what are the common clinical manifestations of UMN lesions? So the first and foremost, the clinical manifestations of UMN lesion is what we see. This is UMN means the first and foremost feature what we see is there is a defect in the higher cortical functions. We all know that the higher mental functions, the higher cortical functions will start from consciousness, orientation, memory, thinking, reasoning, language, speech. All those things are higher cortical functions. Why these are called as higher cortical functions? It is the functions of especially a cortex. These are cortical functions. So if you find somebody with UMN lesion, you will definitely find some dysfunctions in the higher mental functions or higher cortical functions. The second one is the abnormal postural reactions. You will definitely see once the injury occurs. Maybe, for example, the best example of UMN lesion is stroke. Once the stroke occurs, within the after beyond the 24 hours, so you will find there is a changes in the position of the patient. The limbs, that is the affected limb, will be positioned automatically in abnormal postures. So how does it occurs? Because this reactions takes place involuntarily. So the involuntary postural reactions will lead to abnormal reflexes, especially the DTRs, the deep tendon reflex. No, not DTRs, the primitive reflexes, which used to come during our newborn time, and it used to stay for some time. It used to teach all the motor activity, and it has made us to develop our various milestones, physical milestones, and it's kept hidden in the cerebral cortex. It's kept hidden in the means it is dominated by the voluntary control of the cerebrum, and those once the cerebrum got affected by any means, once again these primitive reflexes will come and act as a resultant to abnormal postural reactions. So once you find there is an abnormal postural reactions, abnormal reflexes, definitely that will lead to abnormal tonicity, because it will have an abnormal bombardment, frequent firing of anterior onset of the spinal cord, which will cause a hypertonicity, that is abnormal tonicity. We call them it as either spasticity or a rigidity. Then of course you will find there is a change in the voluntary control. Sometimes the voluntary control will be lost in case of UMN lesions. Then of course sensory functions will not be lost, but you will find there is a sensory deficit, especially the combined cortical functions, sensory functions will be affected. Of course the patient will become functionally dependent, and there you will be find there is a defect in the balance and the coordination. These are the some of the common clinical manifestations of UMN lesions. You will definitely see some clinical features in case of any kind of a diagnosed case of upper motor neuron lesions. Then what are the clinical manifestations of LMN lesions? We all know that immediately if there is an injury to the nerve, the muscles, the tendon reflex, DTR will be absent, and the neuromuscular communication will be affected, and there will be a loss of tonicity, loss of muscle power will become zero, and a loss of diminished sensation or a loss of sensations, and that particular part of the body will be lost, functional loss of the body. These are the common clinical manifestations of the UMN and LMN lesions. Now, to treat these clinical manifestations, which are coming as a resultant to any type of an UMN lesions or LMN lesions, let it be stroke, let it be Parkinsonism, let it be spinal cord injury, let it be head injury. So any kind of an UMN lesions, those are the expected clinical manifestations. Any kind of LMN lesions, those are the expected clinical manifestations. So This is entirely will be managed by a neurorehabilitation team. It cannot be managed by a single health professional at all. It has to be managed by it is a teamwork. So we have got a complete teamwork, and this teamwork, the ultimate resultant of the entire teamwork, we call it as a neurorehabilitation. So what is that? Is a process of bringing back the neurologically disabled patients from the disabled state to a normal or to the near normal level with the help of various available resources in the field of neurophysiotherapy. So this is what is a definition of, or what we get as an operational definition of neurorehabilitation. So now, who are the team? Who are these people responsible for making the best possible neurorehabilitation? The first and foremost thing is patient. Remember, my dear physiotherapists and students who are attending this particular webinar, because it is the patients who are taking the leading role of rehabilitating by himself. So 50% of the responsibility will be in the hands of patient himself. So patient will be the very important person, then the neurophysician and the neurosurgeon, neurophysiotherapist, occupational therapist, psychiatrist, psychiatric counselor, prosthetist and orthotics, rehabilitation nurse, social worker. All of these are the team of the people who will be working for the better neurorehabilitation. So it is not done by any single health professionals. It requires in neuro condition only, we see it is the effort of entire teamwork. If anybody is not properly handled, because the rehabilitation will definitely may not be fruitful. So it is must that patient has to participate in this recovery. It is must that neurophysician should be properly conservatively managed, and it should be properly handed over to the neurophysiotherapist or occupational therapist. And of course, the neuro patients will have their combination of various psychiatric illness. Of course, psychiatrists should be always standby. Of course, some people will require the prosthetist and orthotist help. They may require an artificial limb and the orthotic appliances sometimes. Of course, a nurse who will be taking care of this kind of patients. So it is a completely a teamwork. Only team can execute a normal neurorehabilitation. So what is neurophysiotherapy now? So now, we being a neurophysiotherapist, so all the physiotherapists, we play when the patient is been referred to us, timingly referred to us by the neurophysician or a neurosurgeon for any kind of a neurological disorder. So we as a neurophysiotherapist we play an important. So what is neurophysiotherapy now? So as an advancement in our profession, that is physiotherapy profession, because some 10 years before, 20 years before, if we see, when we are student, there is no evidence of a particular specialty practice. So now, as an advancement in our profession, the departmentalization has been evolved from the past decades. So, and as and when there are so many number of neurophysiotherapists are passed out from various health universities across the country, the branch of neurophysiotherapy has an evolved, taken its roots in the existing practice of physiotherapy. So now, if you see in India, there are more than 5,000 neurophysiotherapists are there. So all 5,000 neurophysiotherapists are serving as a neuro specialist at the respective places. So they are expected to have the what we can say specialized knowledge in this particular branch of our profession. So now, what are the skills they are supposed to expected to have being a neurophysiotherapist? So they are supposed to be mastered in all neurophysiological techniques and its applications, such as Bovat concept, PNF techniques, brainstorm movement therapy, MRP, root approach. This is as far as the interventional skills are concerned. So when you get when you have been referred by a stroke patient, so during that time, which technique to be followed? So after your entire evaluation of the patient, so when you are coming out with the treatment plan, and you should know the best strategies to come out with a good result. So what is our weapons? What is the weapons of neurophysiotherapist? If we see, these are the skills. You should be mastered in Bava concept, PNF techniques, brainstorm movement therapy, MRP, roots. So these are some of the weapons that a neurophysiotherapist should have to intervene in a tailor-based manner. It cannot be used. All the techniques cannot be used for all the patients. Certain patients Some patients may require Bobath concept. Some patient may require PNF techniques. Some patient may require Dunstan movement therapy. Some patient may require MRP. Some patient may require rude approach. Some patient may be a conventional physiotherapy, like range of motion exercise, strengthening exercise, all those things. These are the skills that any neurophysiotherapist is expected to have when they're practicing. So let us come to the topic now. The topic is neuronal plasticity, various concepts. Okay. So what is neuronal plasticity? It's I told you in the beginning itself. It is nothing. It is not the thing which is beyond our knowledge. It is which is happening within our body. The physiological process of remodeling, reorganization, or remapping of cerebral functions. In simple. Okay. So affected part of the brain, affected part of the CNS will have the capability of repairing itself. Okay, so it is by default as a part of the physiological process. It has got its own tendency to remodeling itself, to reorganize the functions by itself, to remap the function itself. It is a normal process that is happening in our brain as a resultant to an injury to the brain. So, what is the hypothesis behind neuronal plasticity? So everybody will think that there are so many, because the word neuroplasticity itself is being evolved and made to understand in a recent decades by various professional experts. So what are the hypotheses behind whether this neuronal plasticity is actually happening in the body? So this is what is a big question mark, because everybody will think that, because in the olden scenario, that is when the 10 years before, 15 years before, before we came out as a specialist, that time what used to be the scenario, once the stroke happens, when the head injury happens, when the Parkinsonism, any patient develops with any kind of human symptoms, that time they used to think that, okay, that's all. The brain is affected means affected. There will not be any possibilities of repairing itself. Jo ho gaya. So there will not be any chances of improving. So this is what is the scenario. When before a neurophysiotherapist come out of themselves and prove themselves, they are effective in treating the various neurological patients and coming out with a good process of neurorehabilitation. So tab tak what was the scenario? People used to think that, once the stroke happens, if there's a paralysis of one half of the body, it means that's all. So that will be paralyzed and he will be having the particular typical position, and he will be continuing his life. And sometimes due to any other infections, he may die. This is what is the situation some 10 years before, 15 years before. But once this neurophysiotherapists have come out and they prove themselves, and they come out with various hypotheses behind this functional recovery. So what are those hypotheses? So first hypothesis is, in case of any damage to brain, it is assumed that the only functionally utilized neurons will be affected, whereas rest of the underutilized neurons will not be damaged. This is what is the first hypothesis. So what is this hypothesis? In other words, so in our lifetime, if in our lifetime or lifespan of 100 years, so we learn the motor skills with the help of primitive reflexes within 1 year. By the end of 1 year, we used to move our body, we used to get up, we should sit, we used to stand, we should walk, and we will do all independent activities, movements of all the parts of the body by the end of the first year. So it means once we learn the mastered in the first year, till our 100 years, the same neurons will be continuing its functions to learn the entire motor skill. To whatever is it is assumed that out of 100% of neurons, we required only 25% of neurons to learn all the motor skills. So it means remaining 75% of neurons in the brain are kept hidden, are kept just like that, kept underutilized, kept unused. So what is hypothesis? The first hypothesis says that if somebody is damages with the stroke, especially, until and unless it is an head injury, severe brain damage, that scenario is different. But when you talk about any acquired injuries like a stroke or Parkinsonism or any infective disease of the CNS, So during that time, only the functionally utilized neurons, that is, suppose if you wanted to move a little finger movements, for the movements of little finger, what all the neurons are there for there, that neurons only will be affected. So like for example, I'm telling, so the entire body functions for all the motor units, so the whole expected functionally learned movements are how much it is, only 25% of the neurons. Remaining 75% of neurons, that is brain, is kept underutilized. It will not be used. So that is the first hypothesis. The second hypothesis is these neurons can be utilized for the newly developing process of motor control. So it is, suppose if the functionally utilized neurons are damaged, means after the acute effect of the illness, acute of the injuries, so those neurons will be cleared. It will be washed. Okay, so then the remaining part of the brain, which is 75% of the brain, will be which are underutilized, will be like as good as the newborn brain. So as good as a new brain. So if you stimulate, if you facilitate these underutilized neurons, which is meant for a specific function at the motor cortex, so definitely this may take up a new program, and whatever the program you are going to give will be accepted, will be memorized by the brain. This is what is the second assumption or hypothesis. The third one is the neurons responsible for higher mental functions can get damaged completely, which will lead to no more possibilities of neuronal plasticity. This is again a third fact about the third hypothesis. It means what? The consciousness, memory, speech, orientation, listening, thinking, all those things, neurons which are higher mental functions. So if these neurons, if there is a damage to this particular area of the brain, it means it damages 100%. Means what? If somebody, if somebody's speech area is affected, if speech is affected, so they will be having definitely, you will not get any possibilities of getting back the speech. Speech affected means affected only. So conscious, that is why sometimes the patient will go to unconsciousness if it is severe damage, and they will not come back. They will become coma, and when the comatose, the above the comatose is death. They go for death. So in majority of the circumstances, हायर मेंटल फंक्शंस जब चले जाता है, अफेक्ट होता है, तो 100% अफेक्ट हो जाता है, because there is no hidden neurons for higher mental functions. There is no underutility neurons for higher mental functions. At the most, you can have the engrams more in that area, but you will not have an underutility neurons as far as the higher mental functions are concerned. These are the hypotheses. Then there are some myths of the neuronal plasticity. There are some misconceptions that is being seen in the practice of physiotherapy. What are the misconceptions? So neuronal plasticity cannot be generated at the central nervous system, because it is strongly believed that the damage occurs at the central nervous system will be permanent in nature, and nothing will be useful at the time at the center by any means. So एक बार CNS affected means it's affected only. So the CNS has got, just now we have discussed, it has gotten various higher mental regions are there, motor cortex is there, sensory cortex is there, the areas of balance, areas of incoordination, area for the various subcortical structures, other things are there. So but previously what the people are thinking is something happens to the brain, that's all, it is permanently damaged. There will not be any possibilities of repairing. That is what is a myth. The second thing is the techniques very much effective at the periphery, and the effects are and they are all transient. So whatever the techniques that the physiotherapists are using in our practice, we used to think that no, it is only effective at the limbs. If somebody is having the spasticity, when you stretch and when you so that only the transient effect will be there at that affected part of the body, but that does not have that will not be having any change at the affected part of the brain. So this is what is again a myth. Again, it is not true, because we'll go to the next slide and we'll come to know. Because we intervene with the good approaches, and the whatever the changes that you see at the periphery will definitely have a relationship with the change that occurs at the CNS, which can be very well found with the various advanced radiological investigations. So the next myth is the very severe neurological conditions are left by the health professions upon its fate. So, so what everybody will think usually, जो भी neurophysician हो or neurologist or neurosurgeon or neurophysiotherapist, so they think that if it is severe, means that's all, there will not be possibility. So it is a fate of the patient. Just that's that they live. So this is what is, again, it's not like that, because every neurophysician, every neurosurgeon, every neurophysiologist, we are very much particular about recovery of the patient by any means. So ऐसा नहीं कि we leave just like that the fate, ऐसा नहीं है. Then last point is, most of the physiotherapy skills are primarily being meant for placebo effect. Again, it is very wrong. It is proven wrong, because the skills that we are using, it has got a neurologically connectivity, connections, and it is having a good effect at the site of lesion. So it is not only for the, it is not the no meaning of no the matlab nahi hai, ye placebo hai. So it is highly physiologically effective skills being used by the physiotherapist. Now let us see the concept of neuronal plasticity. What are the concepts? So based on the hypothesis that is derived by various health professionals, so certain concepts has come up, been evolved in the management of various UML lesions. So what are those concepts? The first one is vicariance. Second one is sublimation. Third one is redundancy. Fourth one is diastasis. These are the various concepts upon which many of our neurophysiological techniques, which I mentioned in the previous slide, is being followed, or is being working on these particular concepts. So what is the meaning of vicariance? So vicariance means, if you remember in my previous slide, I said that in our body movements, there are 25% of neurons are sufficient enough to do the entire lifespan of motor and various movements, whereas remaining 75% neurons are kept hidden, underutilized. So if any approach, if you can make the, if you are doing any process of making use of underutility neurons, that is, which are kept hidden in the brain, if that process, if you do it, if the reprogramming occurs by the underutility neurons, that entire process is called as the concept of vicariance. I hope I'm clear with the first point. The second point is sublimation. What is sublimation? In the literal meaning of the sublimation, or a dictionary meaning of sublimation, if you see, yeah, you know, there are some objects, that is solid objects, which will be directly reaching to other phase without going into the phase of solid leading to gas, without going into the liquid form. That you see, the example, best example in day-to-day life is kapoor. So when you are जब हम कपूर जलाता है ना, so when you're lighting the kapoor, so kapoor will not become dilute, it will not become liquid, it will directly go into gas form. So solid state of kapoor without going into liquid form, it is directly reaching the gas form. That is what is the dictionary meaning of sublimations. So this particular meaning is been implicated even in the process of neuronal plasticity, because we say it is whenever that means the living brain has got the potential to substitute itself, it can reprogram itself without undergoing any process of basics. So suppose that is what we see. If there is any in case of a blind person, acquired blind people, so later on the vision that he lost, that input that will be compensated by means of say sensory input, the sensory functions that has become developed in the hand of that particular person. So the hand functions are basically different from the high functions, but when need comes, the brain has got potential to repair itself. So अगर ये काम नहीं करता है तो that is called as a fail back mechanism. So it will have its own compensatory mechanism to train up. So in that way, brain gets repairing itself, brain gets remodel itself, brain gets remap itself, brain get reorganize itself. So that form of the strategies if we use for the process of neural plasticity, we call it as a process of sublimation, concept of sublimation. The third one is redundancy. So redundancy means what? There are neurons which are damaged and which are it will be kept hidden, it will be unused. So it means waste. So waste neurons will be substituted by the available neurons. So this is called as a functional substitution, in other words called as. So redundant means neurons means dead neurons, waste neurons. You know the literal meaning of redundancy means waste things, waste part. Okay, redundant part, redundant person. In a team, also in a team of 10 members, out of 10 members, 1 or 2 people will be redundant. So they will not be useful at all. But the unuseful neurons will be washed off, or it will be just like that, it will be kept in the brain. The active neurons will take up its functions, and it will reorganize, it will reprogram. So it has got potential to repair by itself. That concept is called as a redundancy. And fourth one is diastasis. What is this diastasis? Is nothing but spontaneous recovery. So some 10 years before or 15 years before, stroke patients especially, when they were when they diagnosed with stroke, and that time no, there is no neurophysiotherapist, or even there is no proper physiotherapist to treat also, but they used to improve by themselves. You might have seen in the society there are so many stroke patients, without taking physiotherapy treatment, they will be moving in the society, they will be independent also. So how this has happened, how this recovery has come up, we might have wondered. So who has treated this patient? Nobody has treated, because brain has got potential to repair itself. Spontaneously भी brain वो repair ही होता है. So but only thing is, when the brain gets repairing itself, somebody should be there to facilitate the normal pattern of recovery. That's all. That facilitation will be done by the physiotherapist. That is what is the role of physiotherapist. So in that way, if the plastic changes, that neuronal plasticity, that neurophysical changes are reoccurring once again, reset once again in the brain, that concept we call it as a diastasis. So that is what in diastasis, no, it is you say without any intervention also the recovery takes place. We wondered, because we might have seen there are so many physiotherapists, so many stroke patients in the society. You might say, if you ask them whether you undergone anywhere treatment, no, they say I admitted here and they were given the treatment. Then I come to my home and I was all right. Now I started moving by himself, functional mobility. He himself tried, and you could sit, then he should walk. Only thing is, he may be walking in a circumflex gait, or he may be having some typical hemiplegic position of the upper limb. Otherwise, he is functionally independent. ऐसा भी recovery होता है. So in this way also recovery takes place. This way also neuronal plasticity occurs. That is what that concept is only called as a diastasis. Next is strategies applicable for best process of neuronal plasticity. Now, what are the strategies? Now, TK sir, we understood these are the certain concepts, these are the some hypotheses, these are some myths, and this is what is this is what we have discussed. Now, agar you should use best process of, so what is the role of physiotherapist here? So we don't want our patients to be walking always with circumflex gait. We don't want our patients to be always bedridden in the bed. So we don't want like this. We want a patient to be, we don't want our patients to be as a patient from years together. So we wanted to do at the early better results हमारे patients को हम लाके देना है. So that is why we should follow certain strategies which will process the better process of neuronal plasticity. A good fast recovery आने के लिए certain strategies we are supposed to use. That is what we are going to discuss in remaining slides. So what is the first concept, first approach or first strategy that is universally accepted for the best process of neural plasticity is Bobath concept, especially for any kind of an acquired CNS lesions like stroke, Parkinsonism, and these kind of problems. The Bobath concept has proven very effective. So how the Bobath concept is proven effective, if you ask me, the principles derived by the Bobath, that is Beta Bobath, Bobath and Bobath, they derived the principles of their management based on the common problems which I enlisted no in the very first slide. These are the common problems of the human lesions. मैंने बताया higher mental functions, postural reactions, hypotonicity, reflexes, all these things. So on that basis, he has derived the principles of his intervention. So then he has counteracted each and every phase of the patient, each and every phase of the clinical manifestations. He has proven better in making the best process of neuronal plasticity. So what are those principles? So Bobath principles are, I told you, these are the common problems like abnormal postural reactions, abnormal reflexes, abnormal tonicity, loss of voluntary control, defect in the sensory motor integration. These are the common problems which I told you in the beginning. So regarding higher mental functions, he is not bothered because there is no possibilities of higher mental functions. So that is why, leaving aside that higher mental function feature of human, remaining features of human के ऊपर उन्होंने ध्यान दिया है, and based on that he derived the principles. So what are the principles of Bobath he derived, if you know? Normal postural alignment. He has strongly believed that, see, any abnormality that you see in case of any kind of an human lesion, especially stroke patient, it is always secondary to abnormal postural reactions. So he is very much believed that you position the patient, you do any kind of intervention, no problem, but align the patient in a biomechanically normally, so that there will not be any chances of exaggeration of primitive reflexes. You position the, अगर supine lying में position करना है patient को, supine lying में head position कैसे रहना है, how should be the shoulder, how should be the position of the hip, how should be the position of the knee, how should be the heel of the patient, how should be the plantar surface of the heel of the sole of the foot. This you decide. You properly plan, properly align the patient, so that the patient will not, the abnormal postural reactions out as a resultant to a abnormal position, no, that will not be facilitated. So usko upar unhone, he was very much strongly believed. So I'll intervene the patient after aligning the patient in normally in normal anatomical position में alignment करके है, he started intervening with his strategies. That is what is the first principle that he followed. The second principle is inhibition versus facilitation. So he started, then it is not practically possible, because when he out of his experience, what he thought, it is not practically possible always to make sure that patient is positioned in a normal position, that what you are expecting, because we will be with patient for about 1 hour or 2 hours in a session, in a day one of the illness, from the day one of the patient. But the majority of the times patient you will be conscious, and then he will try to move by himself. He will change his position because out of his stress, out of the depression, he will be trying to move the limbs. So he decided that it is not practically possible to position the patient always in normal. They move it. So then there will be a possibilities of abnormal postural reaction to set in. So abnormal postural reactions will be the next expected sign of the clinical manifestations of human lesions in the sequence wise also. So whichever is abnormal postural reactions, whichever is seen, he tried to inhibit it. So he has gone for inhibitory techniques for inhibition of the abnormal postural reactions, and simultaneously he concentrated on facilitation of the normal postural reactions. Normal क्या होता है, abnormal क्या होता है, abnormal को inhibit किया है, and normal को facilitate किया है. So that is what is believed on the as that is what is second principle. He concentrated on inhibition versus facilitation. Then the third principle is assessment versus treatment. So now, you know, we all do also. In case it's not only applicable for UML lesions, it is applicable for LMN also. Not only for stroke, for any kind of a patient, not only neurological disorders, even any orthopedic patients could be, cardiorespiratory patients could be. It is very, very important that every day you are supposed to reassess the patient. You have to go for a new strategies, and you should plan for a short-term goal, sectional goal, long-term goal. Then and every day you are supposed to change the every day you should assess the patient, then treat the patient. So upon these are the three principles he strictly followed and made seen that there's a good possible recovery that you could see in especially in stroke patients after following this particular principle strictly. Then the second technique is that PNF. So next strategies what we generally follow, generally expected to know to any neurophysiotherapist is PNF. What is PNF? We all know that it's a proprioceptive neuromuscular facilitation techniques. So proprioceptors are, we all know that where are these proprioceptors are present in our body. So it is present in the muscle, it is present in the Golgi muscles, in the muscle spindles, it is present in the tendons, it is present in the ligaments, it is present in the joint. So it is present in the skin, it is present in the everywhere. So what are the proprioceptors? These are the receptors which are having direct relationship with the motor cortex of the CNS. So, and this is in case of any damage to the, in case of any acquired damage to the CNS, proprioceptors will not be affected. This will be intact. यही belief पे, यही hypothesis का base पे, if you facilitate these proprioceptors in a particular pattern of exercises, so if this proprioceptors will be helpful to facilitate or stimulate the underutility neurons which are not affected at the site of lesion to take up a new function. So that is the reason that PNF techniques are proven beneficial after Bobath concept. So next one is brainstorm. So brainstorm movement therapy and the motor relearning program. Motor relearning program, the brainstorm, what this particular approach strategy is that let any movement come, whichever the movement come first basis, because in stroke patient, brainstorm has found out that the stroke recovery follows a spontaneous recovery stages, that is stage 1, stage 2, stage 3, stage 4, stage 5, stage 6. Like that 6 stages of brainstorm you could see. Even if you don't treat also, the first stage the patient will become all the limbs will be flail, and second stage spasticity will come, third stage will go to peak, then it will decline, and there will be a movements synergy pattern, then isolated movements, all this. This is how the sequence of brainstorm he has observed as a recovery stages in stroke patient especially. So what he strongly believe that let us facilitate the recovery phases of the human lesions. Let the movement come, then we will correct. So that is what he has tried. So it used to support the. I will tell you in the summary that which technique supports which concept of neuronal plasticity, but it supports always the functional substitution, that is redundancy part of the concept of the neuronal plasticity go. Brainstorm movement therapy and motor relearning program supports. Then the constrained induced movement therapy. Again, I told you it is a training of a single limb. Attention, more attention diverting towards only the affected part of the brain. So again, it is going to be more beneficial. It is going to stimulate some concept of neuronal plasticity. So last the strategies is conventional physiotherapy, which are always a combination of range of motion, re-education, strengthening exercises. This particular conventional physiotherapy techniques that whatever we use for the human lesions, this supports the concept of diastasis. That is, I told you in the beginning also, it supports the spontaneous recovery. So when you see there is a restriction of range of motion in the wrist, elbow, and shoulder, if you train the range of motion, there will be improvement. If we find there is a patient could not able to do mat exercises, that is functional mobilities. If you do the functional mobility training, you will come from supine to side lying to sitting. Then when you find there is some muscles are weak, then if you give the strengthening exercises, then you will start walking. And like that as and when the patient comes out with the symptoms, if you manage symptomatically, again there will be an improvement, and that supports the concept of diastasis of neuronal plasticity. So again, now in the summary of the various strategies, to conclude, I wanted to tell you that Babath and PNF, more or less, it supports the concept of vicariance, because they try to work on underutility neurons, whereas Brunstorm, motor relearning program, and those, and even roots sometimes, these are will be working on basis of sublimation and redundancy concept, whereas the conventional physiotherapy exercises, that is symptomatic physiotherapy management, will be working highly on the basis of diastasis, because it helps in spontaneous recovery of the patient. So what is the evidence? So based on the available literatures and the recent advancements in neurorehabilitation, there are certain skills of neurophysiological techniques which I mentioned in the previously. It is proven effective for producing the best possible neuronal plasticity. So now I think we have come to the last before slide. The important factors to be considered to elicit the neuronal plasticity. Very, very important area. I want all the youngsters to note down in your brain. So first one is early diagnosis and early intervention. In case of any kind of an human lesions, so why in ancient days, that is 10 years before, 15 years before, if a stroke patient will be treated by physiotherapist years together to get one improvement to progress from one improvement to next improvement, it used to take months together. The reason is that time a neurologist, they don't refer a patient in time. They refer after the diagnosis, after when they get discharged, after they maybe after 1 month, 3 months, 6 months. So they send very late with an established symptoms of abnormal postural reactions, abnormal primitive reflexes, the typical positions, spasticity होने के बाद they will send to a physiotherapist. That was a scenario some 15, 20 years before. Whereas nowadays, you can intervene at the earliest for any kind of human lesions from the day one of the diagnosis. So once the patient is diagnosed with stroke, even stroke intensive care unit में जाके आपने, you can treat the patient, you can do the positioning, you can do the inhibitor techniques, you can do the facilitated techniques. So it is possible nowadays because the sufficient awareness is there at almost in all the metro cities and in a tertiary care hospitals nowadays. So that is very, very important. You should be referred by a neurologist at the early, and there should be a proper diagnosis at the early, and the physiotherapy intervention should start early. The more you delay, and more will be the delay in the prognosis. The second important point is intervene with the strongest stimulus so that remodeling or reorganization of the nervous system will be facilitated at the earliest. So what it means? Of course, I told you in the beginning, as a neurophysiotherapist, you should have a certain skills as your weapons, but you should know which weapon to use for which disorder. So when you get a stroke patient from the day one, follow Babath, which is the strongest stimulus. Either if you are good in Babath, you follow Babath. If you are good in PNF, follow PNF. But when you get a patient with an established symptoms, don't follow Babath, follow the Brunstorm, follow the MRP. Don't stick on to, "No, I'm best in Babat, I'll follow Babat." No. In that case, even a conventional physiotherapy will be effective. Even a patient is, if a patient is having the problem with established spasticity, and you should know the spasticity management skills. And now in at that phase, if you go and do the inhibitory techniques, it will not be effective. So you should know which stimulus to use for the best process of neuronal plasticity. Agar, if you stick on to one particular stimulus, and you will not get a good result. The third important point is, irrespective of the stimulus used by the purpose of, the frequency and the repetitions need to be uniformly maintained throughout the sessions. So you follow any technique, no problem. But how do you exercise the person on the previous setting? The same way, suppose if you have done a 10 minutes of exercise program, if you want to add on to 15 minutes, see that you inform them you are adding 5 more exercises, it may lead to 5 more minutes. So you follow the frequency, repetitions, 10 repetitions of each exercise, follow 10 repetitions of each exercise. 5 repetitions of each exercise, follow the 5 repetitions of each exercise. If when you wanted to revise, follow it timingly in a different maybe after achieving certain goals, sessional goals achieve होने के बाद, you progress your treatment. You follow a particular pattern of timing of intervention, and the mode of treatment should be of uniform in nature. You cannot you cannot use today one stimulus, tomorrow today Bobat में treatment किया, दूसरा में some other day PNF वाला दिया, some other day some therapist has given some other technique. It will not be useful. Then treatment should not be always one-way process, whereas where the active participation of the patient is very much essential. I told you in the beginning itself, in a neurorehabilitation team, the very important person is patient. The first and foremost person is member is patient. Patient, once he has become conscious, and you should know that yes, I should improve, I should come out of what I am today. If अगर उन्होंने मन लगाया, so definitely you will get a good process of neural plasticity. Agar if you are only giving the treatment, patient is not at all interested, patient is not at all cooperative, and patient is not at all knowing, aware of what treatment you are giving, then absolutely the end result will be zero. Then the fifth point is always continuous motivation and monitoring the outcome is highly valid, because we should know. That is why Bobat strongly believed every day you assess the patient, every day you go for a new strategies, every day you try to see that and motivate the patient, be with patient, and you just take out the highest potential from the patient so that you get a good process of neuronal plasticity. These are the important factors to be considered to elicit the a good neuronal, satisfactory neuronal plasticity. So, how do we know certain things are happening out of our result? It's a we can check by using the high resolution MRI, and there is a neuronal mapping of the brain also nowadays. It is possible. Even you can use multiplanar CT scan, and even many more advanced measures have come. Functional MRI has come, and so you can use any of the measure whenever you do some many higher studies in this particular topic, and you will come to know there is a evidence of neuronal plasticity after the application of your approach. So in the end, I would like to tell you that our past is what we can say, not being continued in the present. So very much past, we even people, all the health professionals, they used to think the recovery of the brain after an insult, after an injury is a doubtful. एक जमाना था, and even physiotherapists also not knowing, not believing themselves, but whatever they are doing is really effective at the affected part of the body also, at the site of lesion also. This knowledge even physiotherapists are also not knowing, and the neurologists are and other health professionals involved, they were not used to believe you. This was the scenario in our past, and now it is not been continued in the present. In future also it is not going to be continued, rather it is going to be more enlightened, and our patients are going to be more benefited out of our interventions. So I wish all the young physiotherapists who are attending this particular webinar, and neurophysiotherapists who are attending this seminar, and all the best. And this is a small knowledge that I shared with you all, and hope so I could do the justice to the topic that I have taken and been approved by the IAP Women's Cell of Varda district. So once again, I thank all the organizers for giving me this opportunity, especially for my teacher, Dr. Soumi Sinha, and special thanks to the Women's Cell National Head Ruchi Varchini and State Head Suvarna Madam, and the entire team of the Women's Cell to making the culture of having this kind of an academic activities, which will be really benefited for all the youngsters who are aspiring to take this profession ahead. With this, I conclude here and open for the discussion with thanking you, all of you. Open to the organizers, and if there is any queries, you can ask. Over to the organizers.
Varadharajulu, it was very nice. You have explained in such an elaborate manner, and the explanation was very, very lucid. I hope all the participants have immensely gained from this. Now, it was really a pleasure to have Dr. Varadharajulu explain the concepts of neuronal plasticity in such a nice manner. Now the session is open for questions and answers. I would ask the participants to type their questions in the chat box. If they have any questions, they can type the questions in the chat box. Meanwhile, we already have 2 questions which I am going to take. Are you ready, Dr. Varadharajulu,
Yes,
for
madam.
the question?
Yes.
Okay. So the first question is, which approach should be preferred if patient is having stroke, right hemi, with cerebellar lesion, right side? And the second part of the question is more of a suggestion, or maybe the second part is, can you please conduct webinars or workshops specific on BOBAT, PNF and MRP?
Yes, madam. So that the second part definitely, as and when the as per the requirement of the people, definitely I will be at their services. There is no problem. And the first part of the question, madam, once again, can you repeat?
Yeah, sure. It is, which approach should be preferred if patient is having stroke, that is right hemi, with cerebellar lesion, right side?
With the cerebellar lesions.
Lesion, yeah.
Okay. No, but like the entire the stroke management, if you see the my presentations, irrespective of the side involvement, irrespective of the part of the brain involved. So when a patient is being diagnosed with the stroke, and if he has been admitted in the if he has been taken in very much earlier to the stroke intensive care unit, from the day one, if we get an opportunity to treat, straight away you can follow the principles of Bobath. So it is going to be helpful for recovery of any kind of a function that is being affected with a even if the cerebral lesions or cerebral lesions, or apart from higher mental functions, it will be taken care of with an early intervention with Bobath.
All right. So we move on to the next question.
Yeah.
That is, which category of stroke patients recover through diastasis?
All the categories of stroke patients will be definitely recovering by the principle of or the concept of diastasis. There is no doubt, but we are not supposed to make the patient to recover by themselves. So we should be very much particular, because diastasis is spontaneous recovery. So every stroke patient will have the potential to be repaired by themselves, but the recovery rate of the prognosis will be always be delayed. and we should not wait for the patients to come to that extent where we will follow the symptomatic management. So always in stroke, we should intervene for the prevention of clinical manifestations or management of clinical manifestations before it sets in the patient. Diastasis can be the principle of the concept of diastasis will be applicable for all the stroke patients, but the approaches that we are using we will be quite later. Maybe at the different stage of recovery, they come to us, and we will be intervening with the symptomatic management, and we could achieve only few improvement out of our approaches. But if you follow the concept of vicariance, and if you are good in concept of Bobath, you from the day one, if you treat within 40 days, madam, they will become independent.
All right.
Yeah.
So shall we move on to the next question?
Yes, madam.
Can the same manner of approach also apply in a CP child?
Yes. Basically, it will be definitely again, madam, in the CP child. Again, for the people who are asking, there is a recent study, not recent study. It's a very old study, but till it is being continued at the, I think in the Australia. I'm not sure of which university who is doing also. But when I'm going through with this, they were doing a study taking the normal growth and development of a normal child versus a diagnosed child of a spastic cerebral palsy. The same day, they were intervened with a NDT approach, that is a neurodevelopmental technique. So the child who was diagnosed with spastic diplegic, you undergone NDT from the day one of the birth, and the child who was born normally on the same day, their physical growth and development is proven to be same. They were improved. So it means what? Whatever the damage that occurs during the phase of the maybe during the birth anaxia, or there are so many causes for CP. So during the time, whatever the damage occurs at the brain, because the CNS also it will be developed completely in the intrauterine life. It will get matured when we become born out. So the maturity may get delayed, but the development happened in the intrauterine life itself. So the intrauterine developed new brain also has got a potential to repair by early intervention with the use of Bobath skill. So it is very much applicable for CP children's. But again, the early diagnosis, early intervention is very, very important.
All right. So next question is, you would have mentioned prior that we are not supposed to use Bobath if patient comes after starting recovery.
Yes,
so the participant wants to know any particular explanation is there for that.
That's what no Bobath. Bobath. The ideal timing for intervention of Bobath is day one of stroke. So if you whatever the expertise you are having in Bobath, because I'm a Bobath practitioner, I don't intervene Bobath patient with an established signs and symptoms of spasticity, established signs and symptoms of circumduction gait. I will not intervene. Even if I intervene also, I will not get a good result. Rather, I will follow a simple conventional approaches. If somebody is having a spasticity, I'll go for a best spasticity management. If somebody is having a problem with the gait, I'll go for the gait training. If somebody is having with the functional mobility, I'll go with the functional mobility training, rather than following a specific particular approach. If you wanted to follow a particular approach, you should go back to the day one. You ensure wherever you are working setup, you just request your neurologist and request them and educate them, create an awareness them that they should refer to you from the day one.
All right. So
because furthermore, what I wanted to say is principles of Bobath is not on the clinical manifestations. He strongly believed on counteracting the clinical manifestations before it sets in. अगर आप एक बार सेट होने के बाद अगर हमने ट्रीटमेंट दिया, Bobath will not be effective. Better you can follow some other technique which may be beneficial.
Okay, so we have one more question. Probably it is the last as of now.
Yeah, madam.
In massive intracerebral hemorrhagic patients with or without craniotomy, where recovery is very slow, which treatment technique can be undertaken?
See, when it case of an hemorrhagic stroke, the scenario is little different from the ischemic. I didn't touch because thinking that everybody aware of the difference between ischemic and hemorrhagic, but still, if the hemorrhagic stroke is the hematoma is been developed, and if there is a possibilities of if they are responding to the conservative management, so it is well and good. Otherwise it damages the because there is no scope of survival of the neurons, because we cannot say how I was explaining in the beginning, the entire 100 years of our lifetime only we use only 25% of neurons for the for various motor activity of our body. But in case of hemorrhagic is as good as a trauma. So in trauma, we don't know how much it is 25 percentage or 50 percentage or it is 60 percentage or 100 percentage. We don't know. But whatever is the residual, if there is a residual neurons, then there is a process of recovery is good. And if the entire hematoma is compressed and necrose the entire brain tissue, which is 100 percentage meant for the specific function, it means the recovery will not be good. So if the hemorrhagic stroke responded for the conservative management by the neurologist, and of course, and if you got the patient in the day one, and of course it is going to be a good you will get a good response by using your Bobath technique or a PNF approach.
Okay, so nicely explained. I hope all the participants have their doubts cleared. And
Yes.
that was the last question. However, we have one compliment from one of the participants, and he has written that it is a very informative talk, which indeed it was.
Thank you very much, madam. It's all your blessings, and and blessings of my teacher, Dr. Rakesh Kumar sir, who is working with all in Maharashtra, in where I'm working in the same state, and my teachers especially. With the blessings of all of you, I could do my best. I hope as a teacher, you like my presentation.
Very, very much. I liked it very, very much. And you were always a very good student, as I remember. And it is showing. And it was really a pleasure to have you here for as a resource person for this webinar.
Yes. Thank you very much, madam, for the blessings and motivating words.
It is always there. Okay, so now I would request Dr. Suvarna Gambhir, madam, to say a few words.
Thank you, Dr. Saumi. Thank you, Dr. Varadharajulu, sir, for that lucid presentation.
Thank you very much.
It was very nice.
Yeah.
And the concepts of plasticity, which are very difficult to understand, you explained it in very simple terms and in a very effective way. So I would like to thank you for sparing your time
Yes.
and being always there with us whenever we ask you.
Yeah.
So thank you so much. And as there was a request by one of the participants to conduct more such webinars on other topics, so we would definitely trouble you in future.
It's my pleasure. It's my pleasure, and it's my duty and my pleasure. I will,
Yes, sir.
my intentions.
Yes, sir. So thank you so much for accepting our invitation, sir. Thank you so much.
Thank you very much. Thank you all for the valuable time.
Yes.
Yeah.
Dr. Stuti?
Madam, hello. Suti is not well, madam.
Okay.
So I think Swami madam will do the vote of thanks.
Okay.
Yeah, sure. I will just read out the vote of thanks that has been prepared by actually Dr. Stuti, but since she is not well, so I'll just read it on her behalf. So on behalf of IAP Women's Cell Vardha team, I propose the vote of thanks to Dr. G. Varadharajulu for sharing his knowledge and experience with us. I also thank Dr. Ruchi Varshini, National Head of IAP Women's Cell, and Dr. Sanjeev Jha, who is IAP President. We are immensely thankful to the IAP Women's Cell Maharashtra team for their extended support. to us. And in particular, Dr. Pooja Kamble, who's zonal head, Dr. Suvarna Gambhir Madam, who's state coordinator, Dr. Snehal Patel, joint coordinator, Dr. Priya Karande, Dr. Uttara Mohan, and Dr. Nirali Sangvi, who are state sub-coordinators. I would like to thank IP India technical team who worked behind the scene to make this happen. Our gratitude also grows to all the participants for attending the event. We request all of you to fill the feedback form, the link of which has been shared in the chat box. Thank you.
Thank you very much. Meet you all in some other time.
We hope to see you soon again for a webinar on some other topic. As Suvarna Madam has said, that we will again trouble you.
No problem, madam. It's my pleasure, madam.
Thank you,
Thank you,
sir.
sir.
Thank you, sir. On
Thank you,
behalf
sir.
of
Thank you, sir. It was very nice
Varadharajulu,
session.
Thank you.
Thank you.
Thank you.